I welcome you all to the last day of INASL 2023. I have a galaxy of luminaries in front of me for this meeting of the Special Interest Group on Vascular Liver Diseases. We have exciting speakers lined up for you, and it's going to be academic bonanza for sure. I invite the Honorable Chairpersons, our very own Professor Subrat Kumar Acharya sir. Sir, please grace the stage. And Dr. Akash Sukla sir. Welcome to the stage, sir. We'll have 3 talks, which sir will introduce, and followed by a panel discussion, for which I'll now invite the respected panelists. Dr. Amrish Sahni sir, Dr. Naveen Ganju sir, Dr. Shrikant Appasani sir, and Dr. Shubhashish Majumdar sir. Welcome panelists. Chairpersons, the stage is yours.
Thank you very much. And this is a special interest group meeting on portal sinusoidal vascular diseases or vascular diseases of the liver. In general, this is a broad term, which of course all of you are aware, that which includes our so-called non-cirrhotic portal fibrosis, which is called as portosinusoidal vascular disease today, and there are or idiopathic portal hypertension, Budd-Chiari, which are hepatic venous outflow tract obstruction, and extrahepatic vascular diseases. And what was previously known as veno-occlusive disease, right, or sinusoidal obstructive disease. These are the essential vascular diseases, despite the fact that there are other vascular diseases, right? I consider splenic artery aneurysms communicating with the portal vein, which is often seen as a cause of portal hypertension, and hepatic endotheliumas. So they are a very broad category, but essentially we take non-cirrhotic portal fibrosis, hepatic outflow tract obstruction, extrahepatic portal venous obstruction, and what is the broad term at portal vascular sinusoidal diseases. And we have 3 talks, and there are some interesting areas. And Dr. Akash Sukla is one of the leaders in the vascular diseases of the liver in the country as well as in the Asian Pacific regions. And he must have read his consensus for APSL. And he is working on the consensus on Indian guidelines as well. And he has already 2 meetings. To start the ball rolling, I will request Akash to speak about the lymphatics in the development and management of liver disorder in portal hypertension, which is quite important because sinusoids are drained by the lymphatics.
Good morning, everybody. At the outset, I must thank Acharya sir for having mentored me throughout my career, especially in terms of vascular liver disorders. It was he who had asked me actually to make a career out of vascular liver disorders. So almost 12 years back, sir, I continue to hope to live up to your expectations in the future. So when we talk of lymphatic system, you have the gut lymphatic system, which starts with the lacteals right in the villi, and then you have the collecting lymphatic vessels, which then drain into the lymph nodes of the mesentery. Please notice that these lymphatics actually have a valve, which is a unidirectional valve. The capillaries and the collecting vessels are lined with what are called as the lymphatic endothelial cells, or the LIACs. In these capillaries, you have button-like loose junctions which make them permeable to the large size molecules. And that is why they are able to absorb the nutrients, fats, immune cells, interstitial fluid, and thereby form the lymph, which flows down to the collecting lymphatic vessels. In the collecting ducts, you have tight junctions, what are called as the zipper-like junctions, between these lyacs, which prevent the lymph from leaking out. The lymphatic valve between the collecting lymphatic vessels allows only one-way flow of lymph. The smooth muscles covering the collecting lymphatic vessels and valves allow the propulsion of lymph to nodes for the immunosurveillance. After filtering through the nodes, the lymph reaches the thoracic duct, which ultimately drains into the left subclavian vein. Let's see what happens in the liver. In the liver, if you see, the lymph is formed in the space of DC, and then it gets collected into the lymphatic vessels, which are present in the porta, along with the portal vein, hepatic artery, and the bile ducts. And from there, you have again the same button-like junctions at the formation, but once it goes to the collecting ducts and goes into the extrahepatic ducts, again you can see the smooth muscle cells to pump it into the cisterna chalae, and you have the tight junctions to prevent the lymphatic leakage. And we all know that it is when these get overwhelmed because of the excessive lymph production, because of the high sinusoidal pressure, that is when you start having rupture of these lymphatics, which form the ascites. So the lymph in the lymphatic vessels is located predominantly in the three regions from the liver: porta, hepatic vein, and the subcapsular areas. The portal tract, the primary site of lymphatic lymph drainage, covers around 80% of the lymph produced by the liver. The fluid in the hepatic sinusoids can flow through the channels traversing the limiting plate to the interstitial space of the portal tract. And there, the endothelial cells of the lymphatic capillaries have discontinuous button-like junctions, which enable the efficient entry of the fluid, antigens, and immune cells into the capillaries. And the capillaries in the portal tract coalesce to form the collecting lymphatic vessels surrounded by the lymphatic muscle cells outside the liver. And these muscle cells, which cover the vessels, help to pump lymph into the renal lymph nodes located in the hilum, and then to the cisterna chalae located at the lower end of the thoracic duct. And the lymph finally drains into the left subclavian vein via the thoracic duct and returns to the systemic blood circulation. Why this is important to note the difference between the button-like junction, which is there in the lymphatic capillaries, because these are, as we discussed, loose and allow entry of large molecules into the lymphatics, while the zipper-like junctions are tight and prevent the lymph leakage. In pathological conditions, whenever there is inflammation of the gut or the liver, the lymphatic capillaries lose this button-like structure and change to a less permeable zipper-like structure, and thereby resulting in impaired transport of fluid and substances into the capillaries, and thereby decreasing the clearance from the tissues and accumulation of lymph-like fluid in the tissues, both in the bowel and in the liver. Now, what are the changes in these lyacs in health and in disease? If you look at when it is normal homeostasis, these lyacs through TGF-beta and NO will interact with the CD8 cells and the CD4 cells, and then they have interactions with the dendritic cells, and they usually present the antigens into the lymph nodes for the surveillance. However, during inflammation, the mediators change. It is now recruitment of different immune cells through CCL19, CXCL3, and interleukin-6. And you can see direct recruitment of the dendritic cells, the neutrophils, the monocytes, macrophages, and the mast cells, thereby causing inflammation in the tissue that we are talking of, whether it is gut or the liver. What about lymphogenesis? We all know that there is lymphogenesis where there is a pathological condition affecting the bowel or the liver. So we have the three VEGFs, A, B, and C. So it is the C and D which predominantly contribute to lymphogenesis, And of these two also, it is the VGF-C, which is the most important, and amongst the receptors, it is the VEGFR3. They activate via the AKT or the ERK1/2 pathway. The co-receptors of VEGFR3 are NRP1 and NRP2. Please remember these because these are what we are going to talk from 2030 to 2040 for therapeutics of portal hypertension. And for want of time, I can't go into the details how these are important, but just remember these names because we are going to talk about these a lot in the next decade and a half. This is how traditionally we know ascites forms. You have increased vascular resistance, increased hydrostatic pressure, increased lymph production, the capillaries rupture, and you have leakage of the lymph-rich fluid. On the other hand, you have arterial vasodilation, splanchnic vasodilation, effective reduction in effective arterial blood volume, thereby causing sodium and water retention, and thereby causing, with hyperproteinemia, fluid leakage into peritoneal cavity and causing ascites. As compared to a healthy subject where the lymph flow is typically 1 liter per day, in patients with cirrhosis, it can be as high as 8 to 9 liters per day. On an average, patients with cirrhosis have 3 to 6 times higher lymph flow rates in the thoracic duct, and the diameter of the lymphatic duct is almost 2 to 4 times as compared to patients without cirrhosis. For those of us who are interested in physics, there's a beautiful mathematical model of the peritoneal space where, as you can see, the inflow is from the aorta and the artery, and the outflow is from the portal vein into the hepatic vein through the sinusoids, and out of the sinusoids, the liver lymph, the hepatic venous flow, the peritoneal lymph, and the intestinal lymph. So these are the different ways of inflows. This is very important because the parameter determining the rate of ascites formation is the pressure difference across the liver capsule, the PL minus PA. In low intraperitoneal pressure states, this difference equals this mathematical model, which of course led to the use of HEPG. And in high intraperitoneal pressure that occurs with appreciable ascites, the equation changes, and you can see it becomes PHEPG by 2. So those of you who are interested, please go back and read this wonderful paper in BMC gastroenterology. The ascites will form when the total flux into the peritoneal cavity exceeds the lymph draining capacity of the peritoneum, which is approximately 50 ml per hour. In the same study, they demonstrated, if you look at the center, that the lymph flow directly correlates with the HEPG. And it is very similar to the graph on my left, that is the ascites volume. And you see the two are almost mirror images of each other, except that the HEPG, the ascites volume starts at a level of 6, whereas the lymph flow excess starts at a HEPG of 8. What about other liver disorders? In liver cancers, lymph node metastasis is seen in 5.1% of HCC and 45% of intrahepatic cholangiocarcinoma. And what are the drivers of this? CCL21, which recruits CCR7. And CCR7 is also expressed by a variety of malignant tumors. And this is considered a causal factor for lymph node metastasis, as the CCR7 expressing dendritic cells cause lymphangiogenesis and cause metastasis into the lymph nodes. The tumor-associated macrophages also play an important role. Similarly, the ICC-derived PDGFD is also recruited and promotes lymphangiogenesis and thereby promotes metastasis into the lymph nodes. What about lymphatics in liver transplantation? So, alloimmunity is established once alloantigens of the graft are drained into secondary lymphoid organs. Post-transplant lymphogenesis in grafts for liver exclusively is actually associated with long-term survival, less chances of rejection, which is very different from any other organ. In any other organ, if you have lymphangiogenesis, it is actually associated with rejection. But in liver, it is actually protective. And why this happens? Because of the hepatic immune tolerance. The dendritic cells present antigens to the T cells and lymph nodes to establish alloimmunity in organ transplantation. And hepatic lymphogenesis contributes to immune tolerance by sending the tolerant hepatic dendritic cells to the lymph nodes after transplantation. What about congenital liver disorders? There's an interesting disease called as lymphedema cholestasis syndrome, which is an autosomal recessive syndrome, primary lymphedema and cholestasis in the neonatal period with intermittent recurrences in the childhood. The Norwegian type is also called as LCS1 because of or the Agenais syndrome because of the same haplotype on chromosome 15q, but also described because of mutation of the CCBE1, which is essential for the VEGF-C activation. So it was subsequently identified in another patient who developed recurrent cholangitis at the age of 52 and a family history of primary lymphedema in lower limbs. What about its use in NAFLD or MASLD? Just a couple of slides, please. Increased lymphatic vessel density in areas of fibrosis and immune cell infiltration in patients with NASH. You have upregulation of genes related to IL-13 signaling, which regulate lymphogenesis negatively by inhibiting the PROX1 expression as well as migration and proliferation of LEGs. The oxidized low-density lipoprotein elevated in NASH livers induces the IL-13 upregulation and reduces PROX1 transcript levels and the LEGs. And the lymphatic transport activity impaired in NASH can be rescued by actually administration of recombinant VEGF-C, and it also causes amelioration of inflammation in the liver. The last important part is lymphatics in hepatic NSF. The meningeal lymphatic vessels are now recognized to be extremely important for hepatic encephalopathy. It is also the target now for a lot of other neurodegenerative neuroinflammatory markers, and manipulation of meningeal lymphangiectasis could be a novel therapeutic strategy for HE, as demonstrated in this elegant paper by Su et al. Published in Gastro. They demonstrated that in BDL rats, there was brain inflammation and lymphangiogenesis, and by giving VEGF, you can actually ameliorate the brain inflammation by increasing lymphangiogenesis and causing improvement in hepatic encephalopathy in rat models. So what are the future directions? We need human studies for these VEGF-C or D, which may ameliorate benign liver disorders by increasing lymphangiogenesis and lymphatic drainage. In cholangiocarcinomas or HCCs, we have to have the opposite way, blocking lymphangiogenesis, because it can prevent metastasis of malignant tumors. And we also need to identify pathways other than the VEGF-C, D, VEGFR3 axis, because they would be additional targets for therapeutics for the liver diseases. So my dear friends, these are exciting times for those interested in the lymphatics, and in next decade and a half, we'll have a completely new era of therapeutics in liver diseases and portal hypertension. Thank you very much.
Thank you, Akash.
I think I'll request you to take a seat. We'll have a discussion later on. Let us have the next presentations by Dr. Krishandas Devdas on non-cirrhotic portal hypertension versus regressed cirrhosis, differences and implications. Well, you have used a new term called regressed cirrhosis, fibrosis reversal. Okay. You have taken a new term called regressed cirrhosis, which is the fibrosis reversal of cirrhosis. So, well, that's a very interesting topic. Dr. Devdas.
Good morning to you all, respected chairpersons, teachers and friends. Actually, this topic was given to me, it's not mine. So when I got the topic, I was wondering whether it is a case of comparing apples and oranges. Let us see, as Rudyard Kipling said, whether the twain shall meet. Now, what is non-cirrhotic portal hypertension? It is just portal hypertension occurring in a patient without cirrhosis. It includes diverse conditions based on resistance locations along the portal inflow and outflow tract. There are a wide variety of conditions. It could be pre-hepatic, hepatic, and post-hepatic. For the sake of this discussion, let us confine ourselves to NCPF, as it is called in India. It is known by a lot of different names. It could be idiopathic portal hypertension, non-cirrhotic portal fibrosis here, hepatoportal sclerosis, non-cirrhotic portal hypertension. And coming to the histopathology, it could be nodular regenerative hyperplasia, partial nodular transformation, obliterative portal venopathy, especially in the West, and incomplete septal cirrhosis. Now, all these have been brought under the umbrella of a new term, that is portosinusoidal vascular disease, which has been proposed by the European Association for the Vascular Liver Disease, or VALDIC, and you all know that how to define PSVD. Now, if you look at the specific features of NCPF pathologically, it could be obliterative portal venopathy, which is present in almost 70 to 75% of cases. It could be nodular regenerative hyperplasia in another 10 to 15%, and incomplete septal fibrosis or cirrhosis, which is present in about 10%. And if you look at the highlighted picture, you can see the incomplete septal fibrosis. The septum comes out of the portal tract but does not go to another portal tract or bridge to a hepatic vein. It meanders into the lobule and ends there. And it is usually thin, not thick, as you expect in cirrhosis. So as I mentioned before, this accounts for about 10% of cases of patients with NCPF, but just hold that in mind. Now, regression of cirrhosis, is it possible? Previously, we used to think that cirrhosis was an inexorable process, finally resulting in hepatic decompensation and death. But reports on regression of cirrhosis have been there for the past 70 years, especially in animal studies. It is a dynamic process. There is injury and repair, injury leading on to progression of the disease, whereas if the injurious object is taken off and you treat it, there can be regression of the disease. This is particularly seen in patients with alcoholic liver disease when they are off alcohol, with HBV, HCV when they are treated, autoimmune hepatitis, hemochromatosis, Wilson's disease, and even in MASLD, as shown by studies on simtuzumab and selonsertib. Now, it goes without saying that the earlier you catch the patient, or earlier you start the treatment, or remove the etiological agent, the greater are the chance of regression of cirrhosis. Once you have a high HPPG, very broad septa, small nodules with an insoluble acellular scar, the chance of regression is quite low. Whereas in early stages, a good percentage can go in for fibrosis and cirrhosis regression, up to 60 to 70% in patients with HBV, HCV, a lesser percentage in ALD, and up to about 5 to 7% in patients with NAFLD. Now, this hepatic repair complex, what happens when the liver tries to repair itself, has been described by Vanless et al. Almost 25 years back. The septa are delicate, are perforated, that is, it's not continuous. There are isolated thick collagen fibers, which are basically cross-linked collagen, which cannot be broken down. Delicate periportal fibrous spikes, which go nowhere. And portal tract remnants, hepatic vein remnants with prolapsed hepatocytes. And as a sign of hepatic regeneration, the hepatocytes go within the portal tracts or even split the septa, which can be seen in the lower, area marked B, and you get a sense of deja vu when you look at the picture on top left. It resembles what you find in patients with NCPF. So that may be the reason for all the confusion, whether NCPF is just incomplete septal, NCPF is just a part of regressed cirrhosis. Now, however the regression of the fibrosis is, the vascular changes may be permanent, especially the capillarization of the sinusoids as seen when you do CD34 staining, which is usually positive only in patients with capillaries in the systemic circulation and not in the liver. And you have to have hepatocyte regeneration. So let us see whether NCPF and regress cirrhosis are different or they are the same entity. So if we compare both, age of NCPF or PSVD is around, usually is in the third or fourth decade, whereas for regress cirrhosis depends on the etiology. age of diagnosis and starting treatment. If you start treatment in a patient late, you get rigorous cirrhosis rather late, whereas if you start treatment by around 20 years or so, you get rigorous cirrhosis even in the first and second decade. It's usually asymptomatic. It may, NCPF usually presents with bleed, whereas for rigorous cirrhosis, if you take a proper history, you can find the etiology, alcohol intake, history of hepatitis B, hepatitis C, withdrawal risk factors, when the patient withdrew the risk factors, history of ascites, jaundice, hepatic encephalopathy, depending on the degree of decompensation can be there in patients with rigorous cirrhosis. Physical examination is one important thing. In NCPF, you get gross splenomegaly, whereas in rigorous cirrhosis, depending on how much the vascular component has improved, you may get mild to moderate splenomegaly. Platelets are low in both. Liver tests, again, transaminitis may be, a mild degree of transaminitis may be present in both. Bilirubin, albumin, INR depends on the parenchymal extension in patients with NCPF. As NCPF progresses, you can have progressive parenchymal extension and derangement of bilirubin, albumin, INR. Whereas in case of rigorous cirrhosis, again, depends on hepatocyte regeneration and extension. Endoscopy, NCPF usually have esophageal varices, gastric varices, and ectopic varices. And the presence of varices in rigorous cirrhosis depends basically on the vascular changes, how much it has regressed. And if you have significantly high HPPG patients, the regression may not be that high, and you may find varices. Now, radiology is another important thing if you want to differentiate between NCPF and rigorous cirrhosis. If you look at the liver, it will be normal or inhomogeneous with irregular surface because of the micronodules. Gross splenomegaly is usually there. Portal vein and hepatic vein are patent and enlarged. And if you look at the walls of the portal vein, and that is quite easy for the radiologist, you find that they are markedly thickened with hyperechoic walls. And intrahepatic branches may be narrowed or occluded by thrombus. So the ultrasound can give a lot of information whether it is NCPF. Whereas for rigorous cirrhosis, the portal vein can be dilated, but wall thickening of the portal vein is not a prominent feature. Same as with enhanced CT. You get a heterogeneous hepatic enhancement basically because of the portal vein supply. There is abrupt narrowing of second degree intrahepatic portal vein branches and paucity of the medium-sized portal branches. And you should remember that there will be a hypertrophy of the caudate lobe in segment 4, whereas in rigorous cirrhosis, you get a hypertrophy of the caudate lobe and atrophy of the segment 4. And for NCPF, portal cavernomatous cholangiopathy has been reported in 10 to 40% of cases, whereas it is very rare in patients with rigorous cirrhosis. And if you look at the VCT, is usually between 7 to 10 kilopascals with a mean value of about 8.4 kilopascals in patients with NCPF, whereas for rigorous cirrhosis depends on the initial value. If you take a patient with a value of 20 or 40, even in rigorous cirrhosis it will be quite high. Whereas if you take a patient with a value of maybe around 12, 13 or 14, then it may fall below 10 kPa. Same as with HPPG. For NCPF and PSVD is usually nominal, slightly raised. Rigorous cirrhosis is usually higher. If you look at the studies on various etiologies, and you find that once the patient is treated, there is a chance that the HPPG can come down from 8% to 30% if you look at the different studies. And again, as for VCT, for HPPG also, depending on the initial value, the fall will also be different. So if you look at the studies on simtuzumab and selonsertib, which has been, the patients have been followed up for about 16 months, you find that there is a 1.4 millimeters fall in HPPG in patients with rigorous fibrosis, and the initial HPPG was also quite low, whereas in patients with higher HPPG, more than 16, then the fall is quite low. It's about 0.2 millimeters of mercury. So in conclusion, rigorous cirrhosis is usually non-progressive, depends on the vascular changes basically, and is associated with a reduction in liver-related complications. HCC can still occur in patients with rigorous cirrhosis. Now, this may be another difference from non-cirrhotic portal fibrosis. NCPF or PSVD can progress with increasing cellular extinction, so patients later can develop ascites and other complications of liver disease. In both, removal of treatment of the etiological factors should be done, and often a careful assessment of the history, a physical examination, etiological assessment should help in differentiating the two entities. Thank you.
And now I will invite Professor Anshu Srivastava, who is from HGPJ, who is a pediatric gastroenterology chief. And I consider her one of the most cerebral young ladies who is practicing pediatric gastroenterology. Welcome.
Thank you, sir. And I would like to thank INASL for giving me this presentation. The topic is challenges and unmet needs in pediatric Budd-Chiari syndrome. So to start with, I would like to say that Budd-Chiari is an extremely uncommon condition in children. It accounts for about 6 to 7% of all chronic liver disease and 2% of children with portal hypertension as defined by presence of esophageal varices. So the first doubt or the first requirement is that we should not miss this diagnosis, and we need to have a high index of suspicion because we know that the presentation may vary with the age also, especially in adolescents. It has been shown that isolated hepatomegaly, even without ascites, which we take as the typical thing of Budd-Chiari, may be present. So always a TAP should be done because we don't always do in the pediatric setup. A TAP should be done in all new onset ascites, and a good ultrasound is mandatory with Doppler to evaluate for Budd-Chiari, even if your index of suspicion is not that great. And the first thing is that there is no consensus, no evidence-based guidelines on the management of Budd-Chiari, and what we do is all based on our experience and expertise, and obviously we draw from the adult guidelines and then we manage our children. So these are the studies which have looked at the prothrombotic states in Budd-Chiari syndrome, and as you can see that the biggest study would be around 40-45 patients, and most of them are from the Indian subcontinent. There are only 2 studies from UK of 7 and 14 patients, and what these busy slide summarizes is that the data is scarce. It is most of the times we have incomplete procoagulant workup and small number of cases if you look across the age spectrum from infants to adolescents. And 40 to 100% of the children in various studies have prothrombotic condition, and multiple causes in really about 50%. In infant, child and adolescent may have a different spectrum of thrombophilia. So we need to know that. Starting from Mumbai itself, there is a series from Abha Nagral's group where they see the infants and younger children with history of diarrhea and dehydration preceding the onset of ascites and Budd-Chiari. And Akash has reported that adolescents have more isolated hepatomegaly without ascites as compared to children. They have less of jaundice and less severe disease. And so is the difference in the thrombophilic spectrum. So we need to have more composite studies which have looked across the ages of Budd-Chiari in pediatric spectrum, and also done all the investigations so that we can decide the things which are applicable to our children. And also there are some conditions which would need specific therapy, like JAK2 inhibitors. Like we have now a growing concern that in our IBD population, especially the acute severe ulcerative colitis, there is increased risk of thrombosis, whereas in contrast to the adult guidelines, a routine prophylaxis for prevention is not recommended in the pediatric age group. So we need to look at the preventive guidelines also so that we don't actually have more and more patients of BCS. Now, medical therapy with anticoagulation, the current APASL guidelines recommend that it should be tried for a small period, but there is no clear evidence in children. That's mostly because most of our children are symptomatic. And there is an increased risk of bleed-related complications, especially in those with portal hypertension and those who are toddlers who are following those who are going to out, smaller children playing sports. So we are basically scared of starting anticoagulation. Look at the evidence. In a study from Mumbai, about 30% patients did well with anticoagulation alone. And the study from King's, only 1 out of 7 patients, but that child had a JAK2 mutation and was on specific therapy for it. From Birmingham children, we have 2 patients who were only on anticoagulation. 1 failed and 1 was successful. So we really need more data as to whether isolated anticoagulation should be the first line of therapy in asymptomatic patients in the pediatric age group. Now coming to a very difficult question, and that is the anticoagulation of choice. The 2 options which are available to us are basically warfarin and a low molecular weight heparin. The directly acting oral anticoagulants, this is coming in a big way. Now there are multiple studies which have started looking into the pediatric age group. They have started looking at the dose recommendation as per the weight of the child. In fact, this is the only thing which is coming as a syrup preparation also, because we have problems in adjusting WAF doses in smaller children because they come only as tablets and administering that also. So the anticoagulation, as I said, is problematic because the hemostatic system is still developing in infants. So we can't have one dose across all pediatric age groups. The pharmacokinetic parameters are different, and we find it difficult, as I said, to monitor and maintain the adequacy of anticoagulation also. You see the INR, you have to increase the dose of WARF by 10%. It comes to about 0.1, 0.2. How do we translate into actual practice? And then the patients have issues with sampling, traveling from remote areas, and the reliability of the peripheral labs as far as INR is concerned. So whether we need to have more of tests, more of the anticoagulations which can be managed without that, or whether we start using a point of care test where reliable tests can be developed which are available in the market, which can be used rather than the proper sampling and the testing for INR. Now going to the radiological intervention, there are challenges in children with small vein size and the hardware choice. We don't have the equipment which is available. So the radiologists, the intervention radiologists are innovating in their own techniques. We all know, and we have shown also in the pediatric age group, that if we do angioplasty alone, the rates of recurrence are much higher than if we combine it with a hepatic vein stenting. But then if the veins are very small, then as per the interventional radiologist, the hepatic vein stenting may not be possible also. The second thing is that it is now a standard of care to use a PTFE covered grafts. But those are not available for TIPS in smaller children, especially infants, and therefore there is a need for re-intervention which is increased, especially when we are using bare stents. So cost is a very big barrier as far what I face in my setup is while managing Budd-Chiari syndrome. Many patients don't even afford the prothrombotic workup, leave alone the radiological intervention, which is expensive. So BCS is an expensive disease, but unfortunately it's seen more often in the poor, and that really stops us from doing all that we want to do for these children. We also need to limit the radiological exposure because we know that these children require multiple re-interventions, and there is a significant radiation exposure with repeated procedures. So now the intervention radiologists use more often ultrasound guidance to access the portal vein when they are doing TIPS. And in the child, the liver is small, it needs more precision, and they feel also that ultrasound perhaps provides a greater anatomical detail as compared to the fluoro. There are guidelines for the reference range of radiation exposure in adults who are undergoing TIPS, but no study has defined a diagnostic reference levels for pediatric TIPS or DIPS. This is a study from All India Institute where they looked at the radiation exposure in 15 children with a mean body weight of 20 kgs undergoing DIPS, and they found that their level of exposure was less than the adult guidelines, but mind you, we do not have any age appropriate in the pediatric spectrum. Then coming to the choice of the radiological intervention, hepatic vein stenting versus TIPS. We all know that in all patients we may not be able to do, there will be select group of patients where we have to offer TIPS because hepatic vein stenting is not feasible. But in case both are feasible, I personally feel, and that's what the literature also shows, that hepatic vein stenting should be preferred over TIPS. That's because the TIPS in the long term can be associated with complications, not only of liver ischemia, liver function impairment, and the cost, but over a long period of time, there's an increased risk of benign liver tumors in these children. And we do not know a child with BCS of 2 years of age whom we are subjecting to a procedure. He has a life of 80 years ahead of him. So it has been shown that nearly 50% of children develop single or multiple hepatic nodules at a mean surveillance time of 4 years after TIPS. So we have to keep this at the back of our mind while selecting the procedure. Now, the liver stiffness with the shear wave elastography is coming up in a big way to help the procedures in pediatric BCS. This is a very nice study from All India Institute where they have looked at 32 children who were subjected to interventions, and you can see that the age range is from 3 to 14 years. And along with the color Doppler, they added a 2D shear wave elastography. They did it at baseline, 24 hours, 1 and 3 months. And what they showed was that there was a significant decline in the value at 24 hours, and this could be used to predict recurrence also because the value went up when these children were developing a block. Similarly, we have a study which we have just submitted, it is under revision, where we have looked at 60 BCS children, 44 subjected to radiological intervention and 16 could not be. And as you can see that with time over a period of 5 years of follow-up, the children who were subjected to radiological intervention had a gradual reduction of the liver and the splenic stiffness both, which was almost touching normal at those who were having a longer follow-up, while those without radiological intervention had almost at the same level or worsening. We need to follow up these children because they are at a very high risk of developing not only just benign liver nodules, but also HCC. So whenever we are following a patient, we should always add alpha-fetoprotein in our BCS patients because that helps in differentiating also from the benign nodules and HCC in this scenario. Again, hepatopulmonary syndrome has also been described up to the tune of 7 to 15% in follow-up of BCS patients, and this can happen even when they are having a patent TIPS or a patent hepatic vein stenting. So the follow-up of BCS children needs to be holistic, it needs to be clinical, laboratory, and I would like to say that we should try to combine an ultrasound Doppler along with a shear wave elastography because it gives us more ideas. We have to look at the not only just the stent patency, but any SOLs and the splenic and liver stiffness, which will help us in following and making a call whether our patient is doing well overall. There's again no normative data for shunt velocities in patients who have been subjected to dips, tips, all those things. And therefore, there is a greater operator dependence for diagnosis of early shunt restenosis. And there also, measuring the stiffness adds to the value because if it's going lower, lower, and lower, you are perhaps more confident. So I would like to conclude by saying that there is limited data on pediatric BCS. The diagnosis may be missed, and we need to have a high index of suspicion and adequate workup. Adolescents and infants are unique groups, they are not similar. A complete prothrombotic workup is required as almost 50% have multiple causes. Anticoagulation is difficult, there is no data on DUAC in Budd-Chiari syndrome setting. Expertise in interventional radiology is absolutely mandatory for treating children, and innovations in techniques are the ones which are going on making us manage these patients. There is a high risk of failure of angioplasty, and if feasible, hepatic vein stenting should be preferred, and inclusion of side being the shear wave elastography along with the Doppler ultrasound would be very useful, and long-term monitoring for hepatopulmonary and liver SOLs. And there is obviously an urgent need for a consensus guidelines on BCS in children because we are all doing what we can and we really need those guidelines. Thank you very much.
Thank you also. Please take a seat, friends. You have understood that there is a huge unmet need in clearly defining, segregating, developing a protocolized approach for diagnosis, therapeutic intervention, and long-term follow-up in this broad group of vascular diseases of the liver. It is across the age group, and you just heard Professor Angshu Srivastava pointing out the huge unmet need in the pediatric age group, starting from its diagnostic criteria, starting from the follow-up criteria, the role of anticoagulant hardly available, whether it works or doesn't work, nobody knows. And what is a thrombophilic state, we don't know, not even the adults. And what do? And do you have expert pediatric radiological interventions? So there are multiple gaps. And you have seen Dr. Kishan Das itself bringing out, right, now there is a group of non-cirrhotic condition in adults, right, and which include, we don't know, this is a funny thing. We described non-cirrhotic portal fibrosis from this country in 1970s by people like Ramalinga Swami, Dr. Naveen Naik, and H.D. Tandon, who had done autopsies, right, and described, and from Japan, Kunio Okuda, which is describing as idiopathic portal hypertension. And we have not found the etiology till that. We had a lot of efforts put in at AIIMS, but we didn't find the etiology. And now we don't know whether in the epidemiology NCPF is increasing or decreasing, right? Professor Chawla, who has been working whole life in PJ Chandigarh and portal hypertension and NCPF, he thinks it is decreasing. It is his impressions. And he thinks extrahepatic portal venous obstruction is decreasing. And you ask Angsu, he says he sees them. So you see the difference of two major centers. So what we need actually now, it is 20th, 21st century, and we have very smart young hepatologists and gastroenterologists, both in adult and pediatric discipline. No, we can discuss this throughout the day. This is the gap, this is the thing, this is the various opinion. But actually, you don't know. So what do? So you start knowing. How do you don't know it? And we have suggested, and we have a very dynamic young man here with Akash, and I will request Angsu or some other young people to join the core group, and we'll start collecting data. We have decided to have a registry across the age group on all vascular diseases of the liver throughout the country, and it will be in a Google spreadsheet. We'll design it, right? And any center can access it, and all the center continue to put in this data. The fields will be clearly designed, and we will communicate it. And Akash is already the principal driver for developing consensus for vascular disease of the liver. And at this moment, he has probably 10 projects on it going on. And he will start this whole ball rolling. And I will request each of you to join in the, whoever is present, and spread this, that we're going to start registrations. And that is the first thing I wanted to know. And this select interest group, particularly on vascular liver disease, was decided because huge unmet gap. Even, as Angsu told very interestingly, now recanalization, establishing a physiological flow of hepatic vein versus a TIPS, even an adult. World over, there's no TIPS, 95% survival if it's successful, also depending on previous liver condition. But what is the long-term outcome? What is the cost effectiveness? How many tips they are putting in? Whether thrombophilic state is influencing it? We don't know. Because we don't have these structural programs, right? It's all right, each center is doing a technique. You see that there is a difference between physiological flow and bypassing the liver using a TIPS over a long period of time. Say for a young child, you have done a TIPS, you have done a physiological function. What will happen? And liver, you know, very well know, your hepatologist, is a site for all metabolism, site for immunotolerance, right? Site for synthesis. Now, you don't provide it, we don't know, there's all short-term follow-up, right? So there is a strong need for this, and there is no doubt about it. And we request Akash that how you are going about to do the register in a time-bound fashion. You can take help of these people. You can, I will say in pediatrics, either Professor Alam is there, Angsu is there. You can invite them because we need pediatrician. It starts in a young age. We may see in an adult, right? But it starts probably young, right? And those who have collaterals, they remain silent. They do not have adequate collaterals. You see them with cirrhosis or ascites, or there is an acute event, right? They manifest. So I think they will be very helpful, and I think we'll strategize, give us a timeline, because we can discuss various issues for a long period of time. But fact is, I have realized from presentation and also from Akash, we don't know anything about lymphatics.
The lymphatics, we really don't know anything. I think we are still in
I
infancy.
will tell you my experience. When we are young, I was a resident, and Yogesh will remember, we have a consultant, his name was Dinesh Bhargav. Have you heard him? He's the first person who published this sclerotherapy from this country. That was my dissertation. This is the first paper in IJMR, first person to start and report laparoscopy. He is the person who used to do diagnostic laparoscopy. We each used to do those days our own laparoscopy. And you will not believe what Akash told, and those photographs will be there also. There will be a huge amount of cirrhotics with big lymphatic cyst on their liver surface. And then Dr. Varga will tell us as resident, this is hepatic outflow tract obstructions. This is not cirrhosis. His outflow tract is obstructed, and these are lymphatic cysts. And that is one of the diagnostic criteria of hepatic outflow, because those days for hepatic outflow tract obstruction, one of the diagnostic criteria was biopsy. Biopsy is nowhere done. It is angiography or ultrasound or non-invasive technique. And nose diagnosis without invasion, we used to see it. I've seen it. Yogesh had seen it. Many of us seen it, what you told. And we don't know anything about that, right? So there are various aspects of these vascular diseases of liver. Essentially, there is a group of patients, what you presented at NCPF, that is a vascular remodeling inside the liver. Why it does? What is the pattern of remodeling of vascular disease? We don't know. You say atherosclerosis. You say extracollaterals, large veins, right? You say some degree of periportal fibrosis. You say it's not complete formation of nodules. That's fine. That is morphological. But you don't have longitudinal study, and you transplant NCPF patient today. At the end of the day, there are studies now, explant liver are NCPF, not cirrhotics. So there are a huge number of gaps in this. So I will request you to give us a structure rather than going on to this endless discussion, what we will do. And next INASL, how we provide a more progressive, right, information on at least the epidemiology and burden on each of the segments.
So I think, sir, thank you very much. I think I agree with you that that is absolutely the need of the hour. And two things which, in fact, I had already discussed with Dr. Alam and Dr. Anshu, that we should have separate guidelines for pediatric vascular liver disorders. So I'll request the two of you to take the lead in formation of these guidelines on behalf of the task force. And the other thing is about the registry. I think that is what we have been discussing for quite some time. So I think we are here. The pediatric hepatologists are here. I would also request at least 2 other young volunteers who are willing to pitch in to develop this registry. Sir, we will develop this in 3 months. Yeah. That is my assurance. And I'll request everybody to participate in the registry. The registry will not be owned by anybody. And like most open registries, the data can be accessed and used by anybody. They can come up with a proposal. It will be passed through the committee, and the data can be used by anybody and everybody who is contributing to the database, the entire data set. So it is not going to be any individuals, any institutes, or anybody else's property. So can we have any volunteer?
I think we have our delegates from Nepal. Is there anybody from Nepal? She is there. I think Nepal, right, from Dr. Sestha's days, from his publication, you have a large number of hepatic outflow tract obstruction, particularly IVC obstructions. Isn't it? Is it still very relevant? Still present? And will you like to join with the INASL as the website? Right. So please contact, because they have a huge number of patients who are the same as Indians actually. Right. And that will be a great information. That's why when I saw you, I thought that we should invite you to join us.
Actually, we looked at the data in our center, past 1 year's admission and some of the OP cases. We found that NCPF, we didn't do biopsy in most, we did biopsy in 2 patients, formed about 1.2% of all the patients presenting with portal hypertension. Portal hypertension.
1.2%.
1.2%. And I think that is almost the same as the Mumbai studies have shown. And whereas in other parts of India, it's about 20 to 40%. This is current. We looked only at the data of the past 1 year. We took 477 patients with portal hypertension. We found that about 5 patients had NCPF, and extrahepatic portal vein obstruction was even low. Because when I was doing my DM and as an assistant professor, we used to get at least 3 or 4 patients every day coming for sclerotherapy. But now we don't get any at all. I mean, very few.
That's exactly so when we looked at our, we presented this at APDW, we looked at 2 decades of NCPF in our center. And when we looked at the absolute number of patients with NCPF coming every year, it was the same. There was no decline. But the total number of patients coming to us with cirrhosis and portal hypertension had increased. So proportion-wise, the percentage-wise, it has come down. We were at 20% 2 decades ago. Now we are down to around 1%, as you said. But if I look at the absolute numbers, it is the same. So the proportion has come down because we are seeing many, many more cirrhotics now. And especially, I think what we are seeing large numbers is alcohol and NASH.
Is it because we are not doing biopsies?
Sir, that is all right. But there are another thing. There are many variables. You see, all our centers are referral centers. Number 1. They are select patients. People reach who can afford. Those people cannot afford, cannot reach. The second, what is evident today. Now, 40 years back, I can count people who used to do liver disease. I was one of them, and there were 3 or 4. And 40 years back, shunt surgery, endoscopic intervention were available at AIMS, PGI, CMC Vellore, Mumbai, and maybe at Calcutta 1 or 2 centers. Rest of the places not there. Now every district headquarter hospital has gastroenterologist with endoscopic intervention. And they do all sclerotherapy in these patients. And since their liver is good, they do well because bleeding and asymptomatic hypersplenism is present. So there are many variables, sir, which has happened. There is a societal change. There is a change in access to healthcare. There is an increased number of experts, and access to symptomatic therapy has improved. So to know that exact prevalence and epidemiology is difficult. But what will happen from a small sample size from your center, if you go across this country and increase the sample size to say 10 lakhs, that will be more representative than an individual center each reporting us, and will be wiser. And that's what I was requesting, because all this fact we know, because those reports, initial reports predominantly from All India Institute told varicose bleeding, 30% of the non-cirrhotic or 40% of the non-cirrhotic. No way true today. It's all different. That day I was trying to tell in one of the symposium, hepatitis C virus was commonest cause of acute viral hepatitis in our country across the age group. It's no more there. We don't have ALF due to hepatitis C virus. It has changed. Because Modi ji should get award. He established toilet across the country. There is no defecation in the field. There is no groundwater contamination.
There is no transmission. So it's gone. So things change according to the factor. So therefore now it is time to rethink, relearn, and redevelop, right? So that we will be wiser, sir. And our next generation will be much wiser than what we are today. That's the request. You agree, Asakas? Do you all agree?
Yes.
Are any?
Morning,
Yeah,
sir.
please.
I just wanted to have a comment on this. Is the thing is that we see this, the cirrhosis that we were talking, we are seeing a lot more cirrhotics. The age has come down a decade. So it could be some of these liver diseases or maybe NCPF on top of another insult. And we see these massive spleens so many times, and which does not correlate to the portal hypertension they have. So it could be NCPF with some etiology, and we label them as alcoholic or something else.
You may be right, sir.
Which is like we see these bigger 20.
You may be absolutely right. I will request other panelists to give their own comments.
Bangalore side has a lot of bud caries.
Okay.
Maybe some geographical thing or some toxins there.
These are all impressions, sir.
Yeah. No, because we see in Bangalore sitting, so
Yeah.
he's saying that you never.
And I'll request others to come give their
I
comment.
remember one of the cases, though we are seeing lesser number of NCPF now, I remember one of the patient who was labeled NCPF, and when we did it was HbS-Ag positive when we evaluated, and we got the biopsy finding also, which was showing cirrhosis. So maybe it is decreasing, incidence is decreasing, but I think biopsy is needed to ascertain the correct diagnosis of NCPF versus cirrhosis.
That's fine. That I understand. Sir, what do you want to say?
Wonderful. The other aspect which we are also actually looking is patients of EHPO and NCPF who are living for a few decades. That's around 1 decade, 2 decades down the line, are slowly becoming cirrhotics, and they start developing these liver cell dysfunction and decompensation.
That's correct. That's correct. That
so-
we don't know also. What is the magnitude? Who
is it
develops
hepatic
that?
ischemia which is
Right.
contributing to that, or something
See
else?
the,
Or
see the
second
gap.
insult?
The disease is in our country. We are all in this country. Nowhere else this diseases occurs, right? And yet we don't know. That is very unfortunate, and that's the need of the time. And any other comment from the house? Because I see very senior people like Professor Chawla, Professor Sima Alam, very bright brains of the country. Sarath, many people who are sitting. Anything you want to add, sir?
Very fascinating talks, very fascinating discussions. Akash, for your first talk, I do remember that for refractory ascites, people used to do stenting of the thoracic duct with the superior subclavian vein. Maybe we need to learn more about the lymphatics, and if the lymphatics rupture, why is there no raise in cholesterol or triglycerides? So we need to study about lymphatics. Then the second, regression cirrhosis and NCPF, I think the incidence has come down significantly, and there is a clear differentiation between NCPF and regression. Regression would only happen if you've given some therapy. NCPF is a different ballgame altogether with thickened portal veins and massive splenomegaly. And I agree that in the pediatric population of Budd-Chiari, you didn't cover the mesocaval and mesoatrial shunts. PGI has had a big series, I think not a very big series. For adults, they've done a lot of mesocaval provided the IVC is patent, or mesoatrial. So whenever you have failure of these intervention procedures, we can resort to mesocaval. And I think Arunanshu has that follow-up of about 10-15 years. I'm not sure what the results are.
So I just wanted to add to the last thing by Anshu, which is an excellent lecture and very informative. The other two lectures were also very good. I still feel that NCPF as well as EHPV and the non-cirrhotic group is still existing, although decreased in children. So it's not like maybe in adult hepatology it's gone down, but not in pediatrics. And another thing that I want to add about NCPF is one more thing that I want to add about NCPF is that having been in a liver transplant program, I think they're the very unfortunate group who can't even get a liver transplant. If you do a liver transplant for such patients, they really do very badly. So we have gone through that misery with 2 or 3 such patients. So this I think, like Anshu was saying, guidelines are very important. And the things that Anshu was emphasizing upon are very important, and I would add one more thing to it is, Anshu, we do not know what size of the dips or the tips that we should leave open for a child. We've had congestive heart failure post tips and dips in these children, and we've lost one child to that. So yes, the guidelines should be in place.
Time now. Anything, Akash, you want to say? We'll
Sir,
conclude.
I had a question to Dr. Krishnadas. Sir, is there any need for the term regress cirrhosis? We have a new term, recompensated cirrhosis. So, what is your take on this?
Bhubaneswar
Can I
has
make a
brought-
last comment?
Yeah,
Yes.
let him answer the question,
Oh,
please.
sorry.
No, Bhubaneswar has recently brought up the term recompensated cirrhosis. That means that the patient was decompensated. This is just a broad term saying that the patient had cirrhosis and there is a regression of fibrosis or cirrhosis. So there is a difference between...
Yeah, so regression is actually a histological diagnosis, and it was coined by Ian Wanless and almost 2 decades ago. And he demonstrated actually in the same patient how the cirrhosis can regress. Yeah, and I think recompensation is too premature right now. It was a very arbitrary term, and 1 year is, I think, too short a term to call it recompensated. I think we'll have to wait to see whether this 1 year can stand the test of time. So, sir, I think...
Okay, I just wanted to say something about what Dr.
You
Chawla
see, in the
said.
world over, yes, please
Sorry.
go.
So regarding the mesoatrial, the context of children, actually, I have not heard the lecture, but I can imagine the problems which we face with radiologic intervention for Budd-Chiari in children is a lot of recurrence and a lot of re-intervention rate, which adds up to the cost. So in resource-constrained settings like ours, we in PGI have now retaken up the mesoatrial shunts, and we have got 100% success so far. We have done only 5 cases, but great results, because this is from the background knowledge we had of the years ago when Dr. Khanna in our institute did a lot of successful mesoatrial shunt surgery. So we are going back to the shunt surgery because we find one-time solution and long-time success without re-intervention. About the EHO, I agree with Seema. We are seeing a lot of EHO again. We had a gap when we were not seeing EHO, but with the improvement of neonatal intensive care and a lot of umbilical catheterizations being done, now we are seeing a resurgence of EHO in a big way, though I can't say the same thing about NCPF.
Very well taken, ma'am. Thank you very much. I think we should wind up, and I think I will ask Akash to take the lead and write to each of you. You will get a communication from him and start the ball rolling. Thank you very much.
You know, it's a wonderful session when we are leaving with more questions than answers and a resolve to find the answers to those questions. I invite you all now to join us on the first floor, Hall A, Hall Konark, for the N. Madan Gopalan oration, where Dr. Anil Arora sir will be speaking to us regarding lessons learned in hepatitis B. We'll reconvene in this hall at 11 a.m. for the next session.